Hi, I'm Dr. Jack West, medical oncologist in Seattle, Washington. At ASTRO 2018, Dr. Daniel Gomez, a radiation oncologist from MD Anderson, presented updated results of a rather small multi-center trial that had findings that were important enough that they arguably should inform our treatment approach for a subset of patients with advanced non-small cell lung cancer. So I'd like to talk about this trial, what we had previously seen, and some updated results that he showed at ASTRO, and then talk about what the findings might mean moving forward. This is the trial design for this study of local ablative therapy for patients with oligometastatic disease. It was a rather small study at the end of the day. It closed early because it showed striking differences in the primary endpoint of progression-free survival early on. So the trial was for patients with low volume metastatic disease who started on systemic therapy with either chemotherapy or a targeted therapy like an EGFR or ALK inhibitor if they had the appropriate driver mutation, and then after 3 months were re-imaged, and if they had very little residual disease, 3 or fewer sites of visible disease and no areas progressing, were randomized to maintenance therapy or observation at the discretion of the treating team, or the same systemic therapy approach with the addition of local ablative therapy, which could be surgery, it could be radiation, it could be some combination depending on the location, the extent of disease, and physician judgment. And patients on that arm also received maintenance systemic therapy as indicated. The primary endpoint was progression-free survival, and the study, as I mentioned, was closed to enrollment early because it showed early on a very dramatic improvement in progression-free survival, and that is shown in the curves on the left here, which was published in Lancet Oncology. He had also presented this at ASCO several years ago. And though this is a smallish study, there was also corroborating evidence in the form of another trial that was done at UT Southwestern by Dr. Iyengar and colleagues, looking at stereotactic ablative body radiation to very little residual disease with maintenance versus maintenance therapy alone. This also showed a striking benefit, though in just 29 randomized patients, and this was also stopped early because of the Data Safety Monitoring Committee decision with these huge differences. So what I found most interesting was not the PFS benefit, because again, you're resecting or ablating the areas most likely to demonstrate progression. So imaging alone is not enough for me, but we did see in that initial presentation by Dr. Gomez that you may be able to change the trajectory of systemic disease with a local therapy, and that's shown in the curves on the right here in the time to new lesion failure. Now here, giving a local therapy to one site is associated with a prolongation of the time before new areas of disease emerge. And I thought this was really an impressive hint that this is a treatment approach that could change outcomes and ideally survival. But we did not have overall survival results from this study. Now, Dr. Gomez did allow crossover in the study, which is why it's particularly impressive that he did demonstrate an improvement in overall survival in the group that received early local ablative therapy. That's shown in the curves here, and you can see the hazard ratio of 0.4 favoring local ablative therapy. The median of 17 months, certainly good enough in patients who did not get local ablative therapy or who crossed over to get it later. But it was 41.2 months in the patients who received local ablative therapy after their initial systemic treatment for 3 months. So really very impressive. Now, I think it's also worth noting that the results seem to be confined to the subgroup of patients with 0 or 1 area of metastatic disease. And that's shown in this subgroup analysis, the forest plot, and I've highlighted that with the box. Now, you can ask, what is 0 sites of metastatic disease? That's just treatment of the primary treatment site. So the primary tumor is still there, but there's no evidence of other disease outside of that. So with just that area to treat or one metastatic focus, outcomes are remarkably better with a hazard ratio of 0.2. And in contrast, in the patients with 2 or 3 sites of disease, metastatic disease beyond the primary, there does not appear to be a clear benefit. Now, this is a subset analysis. It's small numbers in the whole study and even smaller in the subgroups, but I think this is an important point to consider, that oligometastatic means few, and if you go beyond even 1 or 2 sites to much more than that, the true value of local therapy may be lost. We need to look into this further in subsequent studies. Now, what can we take from this? These studies, even when you include a few others like the Iyengar trial, all end up just with very limited data. But these trials were discontinued early due to the findings of local ablative therapy being so superior. Now, PFS to me is not enough, but we're now seeing some indication that we're impacting the systemic trajectory of the disease in the time to new metastases and overall survival by giving local therapy early on for a subgroup of patients. It's notable that the NCCN guidelines now include local ablative therapy as an option for patients with limited disease, though this is really not defined in the NCCN guidelines, and there's just a mention that this could be up to 5 lesions. I would say that it's also worth noting that various trials of oligometastatic disease that are still going on look at a cutoff of 3 lesions or 3 sites or 5, and a couple even go up to 10. And I would say this is where I think it's really important to apply this approach very selectively, that oligometastatic should really be limited to very few sites of disease. And seeing a result that looks beneficial in those with just a primary primary tumor as their residual disease or one metastatic focus is a lot different from presuming that that same benefit would be seen if you treat 4 or 5 or certainly more of these lesions. I would say that just like we know that giving ALK inhibitors can be amazingly beneficial for patients with an ALK rearrangement, it doesn't make sense to apply it so broadly that you're giving ALK inhibitors to people who don't have an ALK rearrangement. Or if we give EGFR inhibitors to patient with EGFR overexpression by IHC, that really dilutes the benefit. And I think that it's very likely that other trials that are being done with much broader definitions of oligometastatic may be negative because they include so many inappropriate patients who are really not demonstrating an oligometastatic biology. I think there's plenty of additional work to do. These trials should be completed, but I think we need to look at these results and pay particular attention to whether the benefits are limited to those with 1 or very few sites of disease, or whether they might possibly apply to a broader population. And in the meantime, I'm far more inclined to consider this approach as an attractive strategy for well-selected patients with 1 or very few sites of residual disease. I think it is an appropriate consideration, but really should be applied very selectively. I'm interested in your thoughts. I'd welcome your comments, objections, questions. I hope you'll like, comment, and subscribe. Thanks very much.